GI doctor in San Antonio. My husband was doing family practice residency, and then I've done a lot of education down through the years, and that's what I really enjoy doing. So we're going to look at liver, gallbladder, and pancreatic things today. And I understand y'all have just finished dermatology. How did it go? Good. I want to remind, what we'll do is I'll lecture for about 45 or 50 minutes, take a break, and then come back and finish it. And I want you to feel free, please, to ask stop me at any time and ask any questions. We all have these slides on your computer at the same time. Okay. And I've got a little bit of extra information that after I made the slides, I just added a few more things, but it's nothing that you can't either type in as I'm talking or find it yourself. So just go ahead and get started. We're going to talk about the liver, the gallbladder, the pancreas, and the duodenum. And I chose this picture down in the corner where it's an autopsy. And you can see some of the structures that they're talking about. You can see where the liver is, and we'll talk about the gallbladder mainly first, and then it's the little green pocket underneath the liver there. And this is going to be strange. Okay, this is the cystic duct. So it comes from the gallbladder itself into the common bile duct, which empties into the duodenum. And then up here you've got the right hepatic duct from the liver, the left hepatic duct, and they go in together. And then as it goes through the pancreas, you have the pancreatic duct. And all three of them, those two will join and then empty into the duodenum. And this, if you want to know, that's the sphincter of Oddi, O-D-D-I. I don't know that that's on the exam, but and some people have an accessory pancreatic duct, and it may or may not empty into the duodenum. But just about every picture I found, they have that, and so they mention it. And so over here you can see the cystic duct, the common bile duct, and then as it comes down to the pancreatic, and then empties into the duodenum. So those are just the structures we're going to be looking at. Just out of curiosity, has anybody here had their gallbladder out for any reason? Okay. And this is just more of a cartoon picture where it exposes things better, where you can see what we're talking about. So for location, it's going to be like right here in the abdomen, not totally central, but a little bit over to the right. The gallbladder typically sits right under the liver edge. And so that's where we'll be talking about. The first thing we'll talk about is cholelithiasis, and that just means the condition of having stones in the gallbladder. There are typically two types. The majority of them are made out of cholesterol, and then some of them are what's called pigmented, and they have breakdown products of blood, bilirubin. And so you see that in people that have hemolytic anemias or other types of bleeding disorders, and that's what causes the pigmentation. The risk factors for having gallbladder disease, increasing age is a big one, and females typically have more gallbladder disease than males. Pregnancy predisposes, also oral contraceptives, or even HRT, which is hormone replacement therapy in women that don't have uterus and ovaries anymore, but want hormones still. Diabetes, especially type 2, since type 2 diabetes is often accompanied by obesity. And there is a familial tendency. It does run in families, the tendency to form stones. Also, rapid weight loss through diet or surgery. And y'all may be familiar with the Nutrisystem diet. And when it first came out, there were so many people that were having such great success with it. But we started seeing a real increase in gallstones. And so really any diet that causes rapid weight loss or the stomach surgery can have a tendency to cause people to form stones. Excess alcohol consumption is a big one also, and we'll see where that relates to pancreatitis later. Also, some of the Native Americans and Mexican Americans have an increased incidence of it than Caucasians or African Americans. Cirrhosis can predispose to it, and like I mentioned earlier, hemolytic anemias. So one of the things that you'll look for in like a African American that has sickle cell disease, or any of the bleeding difficulties you want to think about in that person with abdominal pain, could they have gallstones? The clinical manifestations, most people that have stones are asymptomatic, and they say that up to 15% of us have stones that maybe if we get an x-ray for something else, they'll happen to see them in the gallbladder. So it doesn't necessarily mean you're going to have an attack, but obviously if they're there, that predisposes you. In symptomatic patients, when they have stones, typically there's no fever or it's a low grade. The lab tests is typically they don't have an elevated white count, or it's just only mildly elevated. They do have episodic pain, and it's due to an intermittent clogging of the cystic duct with a stone. And it usually is in the upper right quadrant. It can radiate to the side or to the back or even up to the right shoulder. So that's kind of typical for gallbladder pain. It can be nocturnal or when they're laying down. And it's described as a wave-like cramping, colicky pain, develops usually between 15 minutes and 2 hours after a fatty meal. And it can last up to 4 hours, and they can have nausea, vomiting, and some diarrhea with it, just depending on how sensitive their system is. So that's kind of a gallbladder attack. It doesn't mean that they're infected at this point, because the lab tests are not elevated, and the pain is kind of episodic. And then once it goes away, it may go away after a few hours, and the physical exam is normal between episodes. The complications that can occur just from having stones, the first one is acute cholecystitis, that we'll talk about in just a minute, chronic cholecystitis, common bile duct stones, which is also called choledocholithiasis, cholangitis and pancreatitis, which are much more emergent and serious problems. Any questions up to this point? Okay, the next thing, you diagnose it is if somebody comes in with that scenario, ultrasound has a 95% success rate for finding stones. And then the HIDA scan, if they don't see stones, but they are suspicious, they'll do the HIDA scan, which they will infuse a radioactive substance plus cholecystokinin is injected, and then it tests the contractility and bile secretion of the gallbladder, and so it tests the function of the gallbladder. CT scan is good for detecting stones in the distal duct, like as it goes down through the pancreas and before it empties into the duodenum. And then ERCP, endoscopic retrograde cholangiopancreatography. It's usually not performed just for a gallbladder attack, but it is used for pancreatitis, and we'll talk about that in just a little bit. And then what used to be very common, but now it's not very common, is where they give you the dye to drink, and then in a little bit they would take an x-ray of the gallbladder and see if there was dye there, or if they could see the stones. And it's not done very much because ultrasound has taken its place in some of the better treatment, or the better diagnostic modalities. Okay, so if somebody has this, and the treatment is really just conservative, you can leave them alone. If this is something that kind of comes and goes in a person, you don't necessarily need to treat it unless they go into an acute attack. And the treatment of choice, if they do surgery, is the laparoscopic cholecystectomy. They used to do the open cholecystectomy, which is about a 6-inch scar right along it's perpendicular, or on a transecting the muscle, and it was really painful to recover from because of that muscle being cut sideways. So the laparoscopic has turned it into from a 5 to 7 day hospital stay into an overnight stay, and it's really just much cleaner, and it just is a lot better all the way around for the patient as well as medically. Non-surgical therapy, they do have some medications that are designed to decrease cholesterol absorption and to dissolve the stones, but if the stones are too big, then the oral medication really doesn't work well. And it is expensive, and once you stop it, the symptoms will reoccur. And then there's another treatment called extracorporeal shockwave lithotripsy, and that is for people that may not be well enough to undergo a surgical procedure. And so this is just sound waves from the outside, similar to what they do for kidney stones, to try to break those up. Any questions so far? Okay. All right, so if the stones become too large and if they start obstructing the cystic duct, and that's usually the one that they obstruct most often, then it turns into acute cholecystitis. And that's because the stone is obstructing the bile being able to secrete. The gallbladder is continuing to squeeze and contract, and it can't get past that stone. And so that causes a continuous type of pain. They typically stay for longer than 6 hours. It's severe, located in the right upper quadrant. Can even start as mid-epigastric pain, almost like they've got heartburn after a fatty meal, and they'll complain of, it started here and then it's just gradually moved over here, and now it's just so painful. I can't sleep, I can't get in a comfortable position. They often will have nausea, vomiting, diarrhea, anorexia, where they just don't feel like eating anything. And on exam, this is where you're going to get positive Murphy sign. In cholelithiasis, just the condition or kind of an attack, and they have mild tenderness, but with a sustained stone, they're going to have acute tenderness. Sometimes as soon as you put your hand on their stomach, it'll go rigid because they just don't want you to touch it at all. And so that's one of the big differences, is they are sicker than somebody that just has a gallstone attack. And fever may be present. It can be anywhere from like 99 or 100, a low grade, all the way up to good, 101, 102, 103, depending on how long they've had it, how functional their gallbladder was before, and that kind of thing. And they may even have an increase in white blood count, and it can go pretty high pretty quickly. And then in their liver function tests to determine how well, how high their bilirubin is, and that kind of thing. A year ago, my mother, who was 82, and she had dementia, and she had lost her ability really to feel pain. And so the only indication that she was sick was that she stopped eating. And so I went to see her on a Friday at lunch, and her nurse said that she hadn't been eating well. And so I just started examining her stomach, and I started opposite of where I thought she might be sick. And so I started down the left lower quadrant, worked my way up, and as soon as I got mid-epigastric, her stomach just went rigid, and she just looked at me and said, "Ow!" And so 30 minutes later, she was in the ER. Her white count was already 18,000, and a couple hours later, she was in shock because her blood pressure bottomed out. And that's kind of one of the things you have to look for, especially in older people, or immunocompromised people is they can get really sick really quickly. And so you just have to, have a high index of suspicion. Most people in their 40s and 50s that don't have other diseases and are fully functioning mentally, they'll come in earlier and might not get to quite a critical point. But that's just kind of one of the things you have to be thinking of in the back of your mind. Any questions? Yes?
What is meant by sludge?
Sludge, that's a good question. Sometimes people have had their gallbladder out, but the liver still makes bile. And so it will be just a mixture of the bile and the bile salts and that kind of thing. And sometimes people can get a situation where the sludge is thick enough to where it acts like they're having another gallbladder attack, because they still have that common duct. And so there are that's where some oral medication may help with that. There's a surgical procedure called a Whipple procedure, which is a very large surgery typically done for malignancies in the gallbladder and common duct area. And so it's not uncommon for people to get sludge symptoms of gallbladder attack after those types of surgeries. But it basically is just the bile, that mixes with the salts and kind of can't move through the system as easily. Okay, diagnosis, again, ultrasound, and one of the things that they look for is pericholecystic fluid, and it's like in the lining on the outside of the gallbladder, and it's pretty diagnostic for acute cholecystitis and not chronic disease. And then the HIDA scan, and I told you what it was a few minutes ago, and failure of the isotope to appear in the gallbladder in 4 hours is highly specific for acute cholecystitis, and it just means that the gallbladder is not functioning, and so that would be a good indication it's time to come out. And when you do have elevated temperature and a white blood count elevation, that is an indication to go ahead and put them on antibiotics. And typically you're looking for the broad spectrums to get the gram negatives, the E. coli's. I think I listed them later. So we'll go over them when we get to pancreatitis or cholangitis. And this is actually the cholecystography that we don't do very much anymore, but you can see just how many gallstones are in that, and even up into the cystic duct. So that would probably be symptomatic, right, to say so. And this is just what the HIDA scan is. So if you do an ultrasound and you don't see the stones, then the next indication is to do the HIDA scan to check to see if the gallbladder is functioning or not. And what is the physical exam finding associated with acute cholecystitis? Positive Murphy's, yes. Have any of y'all felt one yet? Had a positive Murphy's? Okay. This time next year, I bet you will. Okay, chronic cholecystitis is really people that just have episodes of that mid-epigastric right upper quadrant pain that comes and goes after a fatty meal. And these are patients that may not be a good candidate for surgery because of their age or other disease processes, especially if they have like lung diseases, and they feel like the doctors feel like that they can't undergo anesthesia, or even heart issues, or just frailty from like a cancer or something like that, and so they can have the chronic cholecystitis. And it may be people that just don't want surgery, and so they'll just come in every now and then with gallbladder attacks, and typically just treat them conservatively unless they have those increased elevations in fever, white blood count, and liver enzymes. And then this guy, he had to take the pickaxe. very many GI cartoons out there. I thought there'd be a whole lot, but there really aren't. Okay, any questions? Okay, we'll move on. Well, let me ask you for, people will come in with the right upper quadrant pain. What else is here besides the gallbladder, the pancreas, and the liver? Appendix is typically lower. One of the things is the colon, the right hepatic flexure of the colon. So people that have constipation, chronic constipation, or even an acute episode, like if they're on opioid therapy or something, and they come in and they say, I just am so tender right here, it just feels so full and pressure, and I haven't been able to go for a few days to have a bowel movement. Typically, you can feel the actual colon full, and you can feel it as it kind of turns into the, what is it when it goes across?
Transfer.
Yes, transverse, thank you. And so that is one of the differentials you need to keep in mind, that it could just be somebody that does have some constipation. Typically, the pain is not as acute as a gallbladder or a gallbladder attack, but it's more of a pressure, more of a fullness, and then they have the history and they've not been able to have a bowel movement. But that is something that you need to keep in mind. And then kidney stone pain is also, you can feel it in the front, typically it's in the back, and it typically is an acute onset, and it may take people to their knees. And it's that, again, that colicky pain that comes and goes. So you think about when you've got an area of the abdomen, think about what all is in there and what could be going wrong, and then just your the main symptom hierarchy of what you might be thinking of. Okay, let's move on. Okay, acute pancreatitis is really a serious disease, and it's an inflammatory disease of the pancreas. The number one reason is too much ingestion of alcohol. And gallstones are the second most common cause, and it can be in gallstones in the common duct or by the duct where the pancreatic duct empties into the common duct, so it can be in there. Metabolic, people that have real high triglycerides also throw the pancreas out. And then pancreatic obstruction or cancer, the pancreatic, like I said, you can get stones inside that pancreatic duct itself. And then cancer of the pancreas can cause, obviously, an obstruction, or even cancer in the liver, the common duct, cancer in the gallbladder, which is, not very, very common, but certainly can happen. And then some of the drugs and toxins that are out there, the immunosuppressants, azathioprine is one, the HIV drugs, furosemide, which is Lasix, a diuretic, the ACE inhibitors, which are high blood pressure medicines, and then estrogens, which can cause the pancreas to go into failure. And what it does is it causes activation of the digestive enzymes that the pancreas produces, and it actually undergoes what's called an autodigestion. And so there's just this serous fluid, and it can make the pancreas even just kind of mushy and obviously not working well. The clinical manifestations, typically they come in very sick, and it usually is an emergency situation where at least you need to get them in the hospital right away. They present with abdominal pain, usually like mid-epigastric, maybe just a little bit lower. That's the hallmark sign. They have nausea and vomiting and can quickly become dehydrated. And because of the age group of people that it's in, it's usually, again, at least least 40. Once they start vomiting, they can get dehydrated really quickly, and then if they also have diarrhea, they're losing it both ends, and so they can really quickly become dehydrated. The pain is described as constant, and people will say it just feels like it's boring all the way to my back. And they typically, are kind of hunched over like this. They don't want to be moved very much. They can, the abdominal exam can vary anything from just minimal tenderness to marked generalized rebound, guarding and rigidity, just depending on how inflamed it is, how long it's been since they've had the symptoms. There are a lot of people that are very stoic and won't come in for things until it's very serious. Bowel sounds may diminish. Again, they could have diarrhea, and so they may be diminished as well as hyper, just depending on what's going on. In necrotizing pancreatitis, sometimes they get bruising along the flanks where fluid has leaked out, and that's called Gray-Turner sign, and then they get some around the umbilicus called Cullen's sign, and those are pretty severe, severely sick people. The lab results that you want to draw, they've got elevated serum amylase and lipase. And the amylase for the first 2 to 12 hours is high, and then it starts to drop off. And then the serum lipase is in the first 12 hours with decreasing levels over 7 to 10 days. And you can also see those elevated in intestinal injury, obstructions, like a biliary stone, and in renal failure. And then also in acute pancreatitis, they're going to have a high white count, hyperglycemia, because if their insulin-producing glands are not working, then they're going to get hyperglycemic. Hypocalcemia, and then the elevated serum bilirubin, outphos, and transaminase are also elevated. And an ultrasound may note the presence of gallstones and the pancreatic edema that's around the body of the pancreas itself. And then the CT scan is used to evaluate the extent and any local complications. And the CT scan actually is a little bit better than the ultrasound to find stones in that common duct. Let me see, I think I made some. They can also be jaundice in about a fourth of the people. About 10% of the people will have shortness of breath, and they'll even have rales because when they can't move air as well, they start, because of how tender the abdomen is, they can get some rales in their lungs. They can have vomiting of blood and even melena, which is the black tarry stools. And sometimes they'll do a KUB, which is just an upright of the abdomen to see if there's free air in the abdomen, because if there is, then that's obviously a surgical type of an emergency. And you have to establish the severity of pancreatitis to predict the course and risk for complications. And there's rancin is what was used here, but I also read about Apache, and which is another kind or another type, and Atlantic classification. And there are like 20 types of things that they use to grade how serious it is and to predict the outcome. And from what I read, not any of them are really so specific that you can bet on them. But it does give you an idea, and I did list rancins, and we'll go over that in a minute. Patients with fewer than 2 criteria have a 1% mortality rate. 3 or more predicts a more complicated clinical course. like I said, you have to hospitalize them. The main goal is supportive care, just to let their pancreas rest. Maintain fluid balance, no oral fluids, until the pain is resolved. Pain control when they are in severe pain, so they do need opioids, and just remember to give them something to help their bowels move too, because everybody gets constipated on opioids. Then you have to monitor the kidney and respiratory functions, because they can fall into kidney failure and also respiratory failure. You have to monitor their blood glucose, and they're finding that the people that aren't even diabetic, when we go into the hospital and we're ill, most of us, our blood glucose will go up. And so it's very common now for any hospitalization, you just monitor the patient's glucose to find out if they do go into a temporary diabetic state. And then if gallstones are present, once they get stabilized, they try to do the cholecystectomy. And you really encourage these people to abstain from alcohol, because that is, again, the primary source or the primary reason that people get acute pancreatitis. So obviously in your history, you're going to want to get a good drug and alcohol intake to see how much they're drinking. And then this is Ranson's criteria, and since it's very obviously, you don't have to write anything down, but it is really a serious illness and can be a real medical emergency. The complications, first is pancreatic necrosis, where the swelling gets so bad that it just cuts off the blood circulation to the pancreas in certain areas, and so it will actually necrose. And obviously that's not a good sign. And if a patient comes in and is starting to get better, but then all of a sudden they decompensate and get worse, you want to think about the pancreatic necrosis. And then they'll have signs of sepsis, which the white count will go way up, and they'll have positive blood cultures. And CT-guided aspiration of the fluid, as well as the antibiotics. And then the antibiotics will be ipipenem, which is the beta-lactamase family. The fluoroquinolone, metronidazole is to get anaerobes. Then some of the complications, pseudocysts, and people that have persistent pancreatitis, diagnosis is made with the ultrasound or CT scan. And people can have small cysts after they get out, and typically those will resolve. The bigger ones may require surgical drainage. And then the renal failure and respiratory failure are a real caution with people that have pancreatitis, so you have to keep that in the back of your mind. And I thought it was interesting that the respiratory insufficiency is mediated through the triglyceride elevation, and I don't understand that. And when I started reading about it, it was way over my head. So I thought, well, I'll just mention it. And anytime we've got hypovolemia and decreased renal perfusion, we're at increased risk for kidney failure. And then chronic pancreatitis is people that just will have it off and on, maybe not bad enough to be in a really serious life-threatening situation. These are people that probably have an alcoholism disease, and so it's very difficult for them to stop drinking. And then if they also aren't watching their diet. And there are people that have genetically mediated high triglycerides. And so these are people that sometimes their first diagnosis of high triglycerides is when they come in with acute pancreatitis. They didn't know they had it before. So, and also genetically high cholesterol. So those are things that you need to watch out for. And again, the abdominal pain is the major symptom. And sometimes in people, when it gets really bad, the pain decreases because the sensory neurons are damaged, and so actually they have less pain, but they're still very, very sick, and so you have to watch out for that. And then they start having steatorrhea, which is fat in the stool, because they're not absorbing that. And of course, they can develop the diabetes because the pancreas can't make insulin anymore. Chronic pancreatitis is suggested by history, confirmed by the pancreatic functions. Sometimes they'll do a 72-hour fecal fat and the cholecystokinin stimulation test. And it's interesting that ERCP, it says, is the most sensitive and specific test for the diagnosis of chronic pancreatitis, but it can also, just by virtue of being in that area, if it misses a stone, it can cause pancreatitis. So they have to be very careful. They really try to look around as much as they can and grab stones, and that's the reason they do the ERCP, is that they have a suspected stone, and so they're going to go try to catch it and get it out. But if they damage the duct and it starts swelling, then it really can be, it can trigger the acute pancreatitis. So the treatment for chronic is, you just want to tell them avoid alcohol, make sure that they know how to manage, they've got medication to lower their triglycerides and cholesterol. And then they have pancreatic replacement enzymes to control the steatorrhea, and then dietary fat should be reduced. And that is often really difficult to do because it's hard for people to change their eating habits. Okay, you've got a 45-year-old female with a history of alcoholism, has nausea, vomiting, and epigastric pain. She states that the pain radiates to her back. Lab results reveal a markedly elevated lipase and mild elevation in serum transaminases. Remaining labs are normal. What's the most likely diagnosis?
Acute
Pancreatitis. And because she only has the two that are elevated, it's probably, she's not terrifically sick at this point, but you still, they can get sick pretty quickly. So you do want to treat it as the pancreatitis until you get results back that would say otherwise. And then, let me see what else I've got here. Okay, the next, actually we're doing really well as far as time. We're about through my whole lecture. The next one is cholangitis, and it's also called ascending cholangitis or acute cholangitis, and it is a medical emergency. And remember the common duct that empties into the duodenum. If that gets clogged with a stone, then fecal matter or undigested food and bacteria can get back up into that common duct and cause an infection, and it can be very quickly go up into the liver and the gallbladder itself and cause some real problems. It can also be caused by benign stricture, and some people just have a smaller opening. Post-operative narrowing for somebody that's had a gallbladder taken out and still maybe they missed a stone or something, and then any of the cancers. And then again, ERCP, the pancreatography, can also trigger the cholangitis. The symptoms are abdominal pain, fever, and jaundice, and this is called Charcot's triad. And then you can also see hypotension and mental confusion just because of the increased bilirubin in the blood and decreased blood pressure, so they can get shocked pretty quickly. Can rapidly develop into septic shock, multiple organ failure, again, kidney and respiratory. The diagnosis is done by elevated white blood count and C-reactive protein, which is indicative of infection. Elevated liver function tests, as you would see like in an obstruction, which is high bilirubin, high alk phos, and Y-glutamyl transpeptidase. And early on, it might even look like a hepatitis because of the elevated ALT and AST. The gold standard for diagnosing is ERCP when it's an intent to remove the stone. And again, it's a balance because they want to be able to get that stone and not cause more cholangitis or pancreatitis. Ultrasound and MRI guided, but sometimes they can miss a stone in the common bile duct, and that's where a CAT scan, CT scan is more reliable for the common bile duct stones. The treatment of hospitalized with IV fluids, broad spectrum antibiotics, and these are the organisms that are going to be involved with cholangitis as well as cholecystitis, gram-negative bacilli, the E. coli, Klebsiella, Enterobacter, and then the gram-positive Enterococcus, and then some anaerobes. And then they need typically IV antibiotics for 7 to 10 days. And that's the end of my presentation. I can't believe that it went so fast. But those are the major things that occur with the gallbladder, the pancreas, and we didn't get into the liver, but that'll come at a different time. So, do y'all have any questions? Yes?
How does a gallstone obstruction make it easier for bacteria to get out of the duodenum?
That's a good question. I'm not certain that I know the answer, but it's just, they just know that when that stone is there, that bacteria, and it can't flow out freely, then apparently just the action of the duodenum can push it back through the sphincter, and they just know that that's the way it happens, but I'm not sure exactly how and how long it takes, if it's a matter of hours or if it's several days or what. Anything else? Okay, so what else will you be doing? You did GI yesterday. You started doing the exams. Okay, and you're working with SPs next week?
Tomorrow.
Okay. Good. Well, it's a fun exam. The abdominal exam for it. All right. I guess you guys get an extra hour.
Thank you.
Thank you.
Thank you.